So, ladies and gentlemen, we'll be starting now our program in time. So, it's interesting. What we'll do is we'll have a slight change in the program. So, I'll request Mr. Peter Downs to give the first presentation on market scope. And then we will go on with the rest when the rest of the people come. Mr. Peter Downs. Either of them, no problem.
Very good. Well, good morning, everybody. Welcome. I'm impressed anybody made it out on the last day at 8 a.m. Everybody gets a medal for that. So I'm going to talk some about ophthalmic disease populations. For diseases other than cataract, I figure after 4 days of meeting in India, you will all have, any of you aren't Indians will already know all about cataract, so I don't need to talk about that. So I am an employee of MarketScope, no other financial disclosures. So the question we're looking at is how many people are in selective ophthalmic disease populations, and we picked these populations to look at: wet AMD, DME, open angle glaucoma, angle closure glaucoma, a couple of cornea diseases, and myopia. And so we break this into 8 regions, and if you want to know the countries that are in these regions, you can contact me later. This is all available, and I will let you know. So looking at wet AMD, this is in thousands. So you see in China, for example, 1.7 million people estimated with wet AMD. In India, 890,000 people estimated wet AMD, and then the number getting treated is just a small fraction of that. For DME, again, China, almost 9 million. These numbers are again in thousands. India, 3.6 million, and only about 45,000 are receiving treatment. Glaucoma in the West, doing a little bit better job, but again, China, here we have 13 million and only about 2 million getting treated. In India, almost 11 million people with open angle glaucoma and only about 1 million getting treated, which I'm sure those of you who practice here know that. The number of people come in late, so a lot of people who haven't sought treatment early enough for it to really be effective. Angle closure glaucoma. Again, this is more of a problem in Asia and Latin America than in Western countries. So China, 10 million, India, 4.3 million, and again, very small number receiving treatment. Fuchs dystrophy, again, is more of a problem in Asia and undeveloped countries than the US. And here you see, you don't even see a bar for the number who are getting corneal transplants from this disease. It doesn't even show up on this scale we have here. Again, population in thousands, infectious keratitis. Rest of the world is mainly Africa and some parts of Asia, leading the way in disease population, not in treatment, and again, in India and China, the level of treatment doesn't even show up on our bar. Keratoconus, especially a big problem in India. And we're looking at, again, this is thousands, so 29.1 million people estimated with keratoconus, and only about 1,000 receiving treatment, or from a corneal transplant. I realize there are other treatments now, cross-linking. I'm not sure how common that is here in India, but in terms of getting severe corneal transplants. So myopia, we looked here at the population with greater than 3 diopter refractive error. And we don't show treatment because we really don't have a way of track eyeglasses that have been distributed, for example. But again, this just shows where the biggest need is around the world. You know, China, rest of the world, and India leading the way. And so I've seen a lot of innovations here in the exhibition hall that I think will help practice is setting up, reaching more people. Here are a few ideas of things we'd seen before that even international companies, I think, are moving in ways that'll help extend treatment. And I think the real trend we're seeing is smaller and more portable devices of all sorts. And one very interesting one is the MyCore 700 from Zeiss. You see the picture there, that handpiece replaces the whole phaco system. And it, I think in the US, it costs about $15,000. So that handpiece is very much smaller than a phaco system and much cheaper. So maybe something that could be available more in secondary level hospitals or smaller hospitals in more rural areas rather than just a tertiary hospital system. And it also facilitates, something that's small, facilitates a movement towards, that people are starting to talk about, office-based cataract surgery. And for that, instead of building a whole clean room, operating room, there are things like the Surgicube, which is a positive pressure environment, sells for about $400,000 in the United States, which is, at least in the US, is many times cheaper than building an operating room. So again, the less money you have to spend on facilities, but can still maintain a sterile environment and do surgeries, the more you can push those surgeries out into communities that maybe don't have access to a hospital. For retina detachment, those of you who go to retina meetings, there's always a debate over whether vitrectomy or pneumatic rectopexy is better. Of course, that only matters if you can afford and have space for a vitrectomy machine, since pneumatic retinopexy can be done in an office setting. And here Alcon has a new product called Unipexy. Instead of a hand filling the gas, it's a pre-filled, adjustable, calibratable cylinder for one procedure. The price may not yet be competitive in a country like India, but other companies, I'm sure, will be developing, modeling similar products. And then that makes possibility, again, of retinal detachment treatment available in a much broader area than just where the people can afford to have a vitrectomy machine. And Alcon is doing this because they've decided to remove all the gas features. They've removed that from their vitrectomy machine, so you'll no longer have the autofill option there. Again, and back to MyCore 700. Developed for cataract, there are people now testing using it to perform vitrectomies with it. And that's almost mind-blowing. Think about a $15,000 device, that portable, that could perform both cataract surgery and vitrectomy. It would really kind of change the equation for making those services available to a lot of people. In glaucoma, in the West, we talk about SLT for OAG, and Alcon has the Voyager, which they purchased from Belkin Vision. I learned here this weekend that SLT doesn't work well in an Indian population because of the heavy pigmentation in the eyes. So if I had a chance, I'd take that slide out right now. For cornea, a variety of new options. There's a brand new drug for acanthamoeba keratitis in the world, just released from CFI in Europe. And we know Orion Biotech has the first approved cell therapy in the world. And there are several companies developing cell therapies, including, I think, some Indian companies for corneal disease. There's my contact information and my colleague Chelsea Jones there as well. And so if you want these slides that you can actually appreciate the numbers there, we'd be happy to share them with you. Thank you.
Thank you, Peter. I think it was something different for us, so many innovative things which can reach out to, places where you can't afford big machines and systems. And nice way to think on, right? Especially a country like India, where we have to reach the peripheral areas. We talk about the healthcare system which should reach the, masses. To primary healthcare, which we are struggling on in this country also. I think these small devices might help in those areas also, where we can't take the big systems. And rapidly, in India also, rapidly the diagnostics have improved, and the country is looking for a sort of a telemedicine network, where we can, actually have a good diagnosis being done in a peripheral area also. You can scan the retina, get the thing done. If we have these type of devices that can be used in smaller places, maybe a good idea. So you can think over, India would be a good market. But the stats you have shown, as per your, market scope, I think, we don't have an accurate, assessment of these disorders in the country. we don't have a survey which clearly defines the number of people suffering from a particular disease. You talked about angle closure glaucoma. Like India, people also don't realize, we also don't realize what would be the percentage of these patients. But we know that angle closure glaucoma in India is very, very high compared to other parts of the world. And that is, people have not looked into. So we need to have a good, I think, people who are working in a community can say better, and especially, you highlighting the various aspects of these managements. Ashi, can you use the mic? We couldn't. What was your question?
So the question was the sources of my data? Yeah, so for those particular numbers, we have we have disease models. So we model the disease. We do that. We have searches that go on continually every year for prevalence studies of disease in different countries around the world. And we feed those into our model and kind of a meta-analysis to then develop our estimates for disease populations. For treatment, it's a combination both of manufacturers of devices reporting to us how their devices are used, interviewing doctors in terms of if they have a device, how much they use it and are treating, and studies that are done. We have in the United States and Europe, we have our own quarterly survey of doctors to see what kind of patients they're seeing and what treatments they're using. For the rest of the world, we have contacts, such as our friend, the SETIs we talk to get information on a less formal method. I'm sorry.
Not too many researches or surveys. I just wanted to know if the data is through any research or survey. No. That you
That
just
is
shared?
from, so some of the data is from surveys.
Some of them are.
Yes. We have a survey that is available to doctors worldwide. Most of the participants are from the United States and Europe. But we have again, surveys for doctors. We have a bank of doctors responding to surveys. And in fact, if you are interested in participating, I can give you a card and you can follow up.
Thank you, Ashi, and thank you, Peter, for a nice presentation. Let me request now Dr. Arun Sethi, who's going to talk about taking ophthalmic care to our community. Arun.
Thank you very much, Professor Tityal. It's a great honor to have you as Vice Chairman and also to present this topic. Well, as you all know, we are a little different. We are a group of private practitioners, a family of private practitioners who started doing community work. We saw our first patient when we came back from Aravind in 1990 under a tree. We had no infrastructure. And we've grown from there to cover now 1.6 million poor patients. And we have our own institute in Gurgaon and outreach services in Delhi. So I'll start the thing by saying how to take ophthalmic care to the community. The first thing is you have to have a clear agenda. That is, you should know what is community ophthalmology, what is the importance to integrate eye care, what are the 6 pillars of health system that you're working on, the strategic 5 modules, and the case examples and the challenges that you face. And of course, at the end, the future directions you want to take. So what is community ophthalmology? Community ophthalmology actually means when you merge public health, community medicine, and ophthalmology. That's in simple terms how you do community ophthalmology by taking it to the masses. The focus is prevention, early detection, and blindness prevention at the community level. Now, if you can solve most of the issues at community level, then the hospitals get decongested and you can do more systematic work there. Now, why community care? As you can see, that India is the land of curable blindness, and what we show you here is that treatable blindness is the largest portion, which is about 68.1%, and the preventable blindness, which you can see in PHCs and all, is the number 2. And you can also see in the visual impactment slide that the treatment, we can actually do a good job at curing 90.4% of the people by just treating them at primary level. Now, why community eye care? Now, 2.2 billion people are visually impaired worldwide. 55% of these needing care are women and girls, primarily from low and middle income countries like India. And many of the eye conditions are preventable or treatable with proper prevention measures or education. Now, what are the 6 pillars of the healthcare system that I've explained? One is system building blocks. So you actually can see that we can cover a lot more by giving service delivery and health workforce, health information systems. They all contribute toward making a quality, safety and access coverage. And then you have the overall goals and the outcomes that come with it. Now, the service delivery. What is important in healthcare is that it should be accessible and equitable eye care programs. So people, Dr. Rohit Khanna from LVP will be talking about that. The health workforce, to have trained eye care professionals, personnel and community volunteers. The community volunteer plays a very important role. It cuts down your cost. It has people in the area who know the population, who can motivate them. So it plays a very big role. Then health information system. Now data has become a big thing. So you'll notice that most of the companies are crunching data and actually surviving on it. One of them is Reliance. And then you have the essential medicines and supplies which you can reach out, because if they are available at the grassroots level, you'll find spectacle dispensation and all that, taking intraocular pressures. It saves a lot of hassle on the part of the patient to come to the hospital. Now, leadership and governance is of prime importance in the community because of the engagement in planning and oversight and in the delivery systems. Now, how do we integrate eye care into primary health care? Eye care has to be a part of the universal health coverage. Unfortunately, it hasn't received that kind of importance, but it deserves. And Professor Praveen Vashisht is here with us, who's been working on it. Then we have co-location of eye care services with primary care. So wherever you have already standing primary health centers of the government or even community halls and all, you can use these to integrate them into centers where a team can go, say, once a week, once a month, depending on the need, and provide the basic services. And those who require referrals are then referred. Then there's an improved referral pathways and monitoring systems. A lot of our patients who we screen in the camps and all get lost. And there will be bigger experts who will tell you that if we go to an eye camp in a village and we screen, say, 50 patients of cataracts, usually not more than 30% land up for surgery. Till you build up a certain reputation, or depends on the enthusiasm of the local organizing committee. So a lot of hard work gets wasted, whereas if 100 are recommended cataract surgeries, 99 should be having them. But that is not the case. Of course, people have a choice, they're scared, they don't want to take a decision, or they don't want it quickly. But the fact remains that we need to have a better output. Then what are the models to do? One is community empowerment. It's very important that eye health education and awareness campaigns are held, and people at the community level are empowered to be able to participate. So we find that wherever we go to centers where the local organizers have done 10, 15, 20 camps enthusiastically, the outcome is much better than where we go on our own, advertise and then organize. Second is hospital-based outreach. So one example is the Operation Eyesight Universal or our team. Now ours is also a base hospital approach, which we learned when we were at fellowship in Arvind, where you go into the periphery, screen the patients, provide basic services only, but bring them back or refer them back to your hospital for further treatment and surgeries. So in the good old days when the camps were done, surgical camps used to be held, I remember with CMC Ludhiana, now that system is over and most of the patients are brought back to a proper OT and operated upon. Then there's the integrated service delivery. A lot of times in eye camps you have patients who come there and say that, we have hypertension, we have diabetes, and we say we have no treatment, we are here only for eyes, and they feel a little slighter. So if you can add these also, then it makes it easier, and if you can incorporate eye care in indications into the national health system, it becomes easier. Technology use, of course, tele-ophthalmology now is a big thing, and you can see we have sessions of that in this conference also, and there's a separate society on how to do that. So what are the success stories? Now you can see that patients have been examined through hospitals. These are the various figures, and we are doing better every year. I won't go into the data because that's Mr. Praveen Vish's area, but as you can see, every year the graph is rising. Now we're reaching a stage where we might plateau out after some time because of the volume that we are doing, but then that's also a good sign, but still there are underserved areas in the country. Now, challenges in community eye care that we feel, one is limited resources, financial, material, and human resources. The first thing is that the level of the non-profits like we run, a small organization, raising consistent funds is very, very difficult. You have a donor, he comes in for, say, 2 camps, 5 camps, or 6 months, and then he says, now, I want to do something else, or I finished my budget. Whereas if you're in a government service like All India Institute, you have a fixed budget over the year, and you know how much you have to spend. And Dr. Titial, when he was the chairman, was quite liberal in spending that money for community care. Then the other thing is overburdened primary healthcare workers. Recently we did a program to train the ASHA workers in our district in Gurgaon and Pataudi. It's very interesting. The feedback that the Commissioner office got was, A, if we help you with finding cataract patients, what is the incentive that you will give the ASHA workers? Nothing is done for free. So how much will you pay them? Because they go there, they identify the patient, they accompany the patient, and there was no budget allocation for this. So we decided as our own as an NGO to give a reasonable amount so that they would be motivated. So that is point one. It's very important to know that nothing happens without monetary gain. Second was that they said that they are overburdened because there are other programs. So the government is loading program after program on them, they claim, and they're not able to serve. Third was inadequate referral system and poor supply chain management. Now if we see somebody in one camp and he doesn't come up, when we ring them up, either they've changed the SIM card or the number is not correct, or even if they're hearing it, they say we will decide when to come. So we lose out on a lot of patients that way. And the other thing is that our staff needs continuous training, empathy and supportive supervision. Now, how do we overcome these barriers? So it's very important to strengthen partnership between governments, NGOs and community. We have to work at one level. It can't be that the government has one plan, the hospital has another plan, and the community wants a third thing to happen. Most of the time in camps, there used to be an emphasis on free medicines, glasses. Ab muft kya de rahe hain? We have moved away from that, and we are saying we are giving a service delivery for those who need it. So it's very important to tell them it's not a freebie, but it's actually a community service. Then there's continuous capacity building and training programs. So we have to keep increasing the capacity as the workload increases, which means investments in infrastructure, running costs, then enhancing our health information systems. Then comes finally sustainable financial strategy. Now this is the toughest for NGOs, because how do you get a sustainable financial system when you're not sure of what brings tomorrow? So you actually face challenges at every day. And the ones who are lucky enough to grow to a certain size, then they are the ones who attract most of the bulk of the donations. So what are the future directions that we recommend? One is emphasize people-centered care and integration of rehabilitation services. So wherever there's a rehabilitation service, if they don't have eye care services, it could be considered to add on to it. Leverage technology for remote screening and referral. Now we have a lot of equipment available which is handheld, like a Perkins tonometer and other things. You can take intraocular pressure, you can do vision with the screen, you can grind and do spectacles right at the spot, as you can see a lot of hospitals are doing. You can scale up in terms of hospital, there's healthcare and so on. So you scale successful models and share the best practices that are being done globally and all over the world. And you increase the research and pilot projects to refine and integrate approaches. So in conclusion, community engagement is key to achieving universal eye health. Holistic integration strengthens both eye care and overall health systems, and the call is for collaborative efforts among the stakeholders. If all those providing community eye care could actually pool the resources to some extent, a lot of knowledge, information and equipment can be shared. So with this small talk, we thank you very much for your patient hearing, and I request now Professor Tityan to take. Any questions?
Thank you, Arun. Making this, I think this is the initiation of this session. We are looking for how to improve the primary healthcare areas, that is reaching the community. I think it was a wonderful insight from your side. You'll be talking? Next speaker? Dr. Rao is not here, no? You're going to do, Dr. Khanna? Okay. Now we'll request one of the most successful programs which has happened in the country through LBPI approach, and we'd like to know what was their initiation, how they achieved these goals, and what are their future goals to achieve this primary health care in the community.
Good morning, everyone.
Dr. Khanna.
Good to see a couple of people in the morning session, 8 o'clock for this session. So on behalf of Dr. Rao could not make it, so I'm just trying to, it's difficult to get into his shoes, but still I will try my best to give you a brief overview of the community ophthalmology model for L.V. Prasad Eye Institute. And this is the approach. So if you look at overall India, I think we have done a significant amount of work. I think it's efforts of each and everyone sitting in this room and not also in this room. which led to the reduction in prevalence of blindness from 1.4 in 1976 to 0.36, which is now. But still the absolute numbers are not going down because the population, that time 1976, the population was 40-50 million, but now the population is 1.5 billion. So even if despite all our efforts, though the prevalence is going down, the absolute numbers are not going down. So we have to have some different kind of approach if you want to reduce the absolute numbers also. We also looked at what's the cost of blindness at the national level, and the overall cost of blindness is almost $54 billion, which is 0.6% of GDP, which is a huge amount. This paper was published 2-3 years back in AIOS. And what Dr. Sethi pointed out, the number of challenges, I think everybody faces these challenges. So I won't go into details of these challenges, but basically it's like human resource, quality, infrastructure, technology and all that. So how do we leverage whatever we have? So challenges will be there. So how do we leverage what we have to better give the optimum services? So coming to this, I'm just give you a brief overview of LV Prasad Institute model. So we don't have a camp-based approach. I think most of the country follow camp-based approach, but we go to the community and put permanent facility. So because of that, we have now, we are located in 3 states and almost to some extent in Karnataka at 308 locations through primary and secondary and tertiary care. So this is one of the largest eye care network in the world, and also I think I don't see, we were looking at healthcare network, I don't see any healthcare network also having this kind of spread across different states. The entire system is built on 10 functional arms, has 10 functional arms and 5 core values. I think we make sure that there is no compromise on these 5 core values whenever you look at any programs. Coming to this, the entire model was built on, the foundation was based on the Andhra Pradesh eye disease study, which was a seminal population-based study which we did almost nearly 3 decades back. And this entire health pyramid was based on that, and we have at the bottom of pyramid a Vision Health Guardian, which takes care of eye care of 5,000 population. At the second level, we have a primary eye care center, where we have a high school trained graduate for 1 year to do refraction, referral, dispensing of glasses, as well as rapport with the community, and also do teleophthalmology and other technologies. So this is typically a vision center, what you see in an outpatient department of any ophthalmologist actually, which is like a slit lamp, applanation tonometry, fundoscopy, dispensing of glasses, and teleophthalmology. So this is typically what they do, and they have a app in which you collect the entire data is stored. When we were looking at this vision center long back, what we found was like, they are picking up all the conditions what an ophthalmologist will pick up. They were able to pick up cataract, corneal conditions, refractive error and all that. What they were missing was glaucoma and retinal pathologies. That means all the posterior segment conditions were missed. So almost 2/3 to 1/4 of the 3/4 of the posterior segment conditions were missed. So how do we make sure that they pick up? Because when we go to camp also we miss all these things. So, and in the vision center also they are able to pick up, but not to the extent what an ophthalmologist will pick. So how do we improve that? So based on that, we designed a study which is called LV Prasad Glaucoma Epidemiological Molecular Genetic Study, which is called GLEAMS. And what GLEAMS found out was non-mediatic fundus camera and FDT will improve the sensitivity of picking up glaucoma and other posterior segment conditions. But when we looked at the cost effectiveness, non-mediatic fundus camera was much superior compared to FDT. So that is the reason we had, it was not based on somebody's whims and fancies that put a camera there. It was based on hardcore evidence, this was a PhD work of 2 students, which came out that using a non-mediatic fundus camera will improve the sensitivity to not to 100%, but 70 to 75%. It's not still reaching 100%. Based on that, we designed a new generation vision center, which is called Futuristic Vision Center, in which incorporated fundus camera and also a ohm perimeter, which does the visual fields. And this is what was the difference. We found that in conventional vision center, what was showed in the previous part, they were able to pick up now all the posterior segment conditions. They were able to pick up many other anterior segment conditions and all. And travel time of the patient was reduced. So care was being provided at the doorstep. So one thing which is different from camp was like people can access this care anytime they want, anywhere they want. So we were closer to the community that way. In terms of now coming to the camp approach, so we were looking, there were multiple approaches. Now we can debate that camp is much better than these people. I can see 100 patients in a camp, I can operate 50 in one go, you operate 10 only in one go. So we looked at different models. A camp approach is one is door-to-door screening. People do door-to-door screening, Universal Eye Health, which Operation Eyesight is doing, and other partners are also doing, where they pick up people from door to door. The third was school-based screening, and fourth was a vision center model. So we looked at whether what is good in long run. So we looked at all the data of all this from 6 partner hospitals. It is not from only one hospital, but it was from different partners. We took 6 partner hospital data, and what we found was, in short term, the red dotted line what you see is, in short term the camp approach are very good. You will pick up immediately, the returns are very good. But the can I have a pointer here? It's not a pointer, you can use mouse. If you look at this blue line is the vision center line. This is the most sustained effort over a period of time. If you want, you can do camp once in a while, then you go after 2-3 months, do one camp, you go after 3 months, do one camp, then there is a break, summer comes, you don't do a camp. So when we looked at the entire thing, what we found that in terms of long term, say more than a decade, the vision center approach are the most cost effective approach in terms of the returns for investment actually. In terms of the number of patients seen, school screening is also good, door to door screening is okay, but it's a slow process. But in terms of cost effectiveness, the vision center approach is the best in terms of long term investment. So this was published in the Lancet Regional Southeast Asia Journal. So these are some of the numbers. I won't go into details of this number. So in a day, we see almost like 6,000 to 7,000 outpatient across the network, and of which almost nearly 25% are seen in the primary eye care network. Coming to the third level, where is like service center, where we have, and these are almost we have 24 service centers at this point in time. This is the place where ophthalmologist is there. So ophthalmologists don't go to the camps, but we bring, these patients are transported from vision center to the secondary center, where they provide all the kind of care what a regular ophthalmologist will do. So we have he is supported by an eye care team of 25 to 30 people, and these are the number of surgeries they perform over a period of time. And in terms of financial sustainability, they are almost like break even in terms of income and expenditure by doing 70% services free of cost. Now coming to next level of what we did was, next level is using the teleophthalmology across the network. So this is what we use, teleophthalmology across the network, where we are able to pick up all these conditions. So these patients need not travel. So using teleophthalmology, we are able to pick up all the entry segment and most of the posterior segment conditions also, and so that patients don't have to travel to long distance for care. And also we make sure that people who are emergency, when you go to camp, you don't know what is emergency, what is non-emergency, but we make sure that whatever are red are emergency are taken care immediately there and then. So we make sure that emergencies are transported faster. We use some of the innovative device from our centers, and then also there is a real-time ROP my colleague Tapas is doing in Bhubaneswar Center. In terms of providing specialty care, now in the camps we don't provide specialty care. So what happens is, now our specialists go to the secondary care center and provide specialty care there. At the same time, what we found that corneal transplant is also being done there. What we found that follow-up care is much better at the secondary care. The compliance to treatment is much better when you do a transplant at the doorstep rather than doing at a tertiary care center. These are some of the retina services which we do. So what we do is, when the retina people are going, we have a van which has the diagnostic equipment. So they will also go to the center on the same day. The retina faculty is there, and all the investigations, OCT, V-scan, fundus photos, everything is done there and then itself. And the treatment, 90% of treatment are given there. Those who require surgery are asked to go to a higher level of care. Also we have a home care model where we are going to home of people who are disabled. These people also will not come to your camp because these are disabled, they're not able to walk also. So we are trying to provide home care at the doorstep. This is one of the concept paper which we publish. I won't go into the video of the home care in the interest of time. But overall, if you see what we have done, so if this center is a center which is located in one of the most remote rural areas in Adilabad, which is called Mudhol. I think Vaibhav knows about it. So what we have done, putting this center almost like more than 25-30 years, what we have seen that significant reduction in prevalence of blindness, because we were there permanently available and people can access care, we afford care, and we are available for them whenever they want. Another example of vision center giving universal eye health, when we developed vision centers, this is example of 7 vision centers we had in around Mudhol. What we saw in 10 years, vision center has covered almost 45% of the population. So almost half of the population have access care, and now we are doing a model where we are trying to see that how do we cover each and every person in that house of a vision center coverage area. With this, I would like to end, and thanks to my entire team. I think these are all efforts of my entire team who is working on the ground day in, day out. Even when I am here, they are on the ground there. Thank you very much. Yeah, but
Yeah, you can come to the mic there.
How much do you think the role of the EMR and how has that improved your outreach activity?
yeah, so EMR once is like at the visions, we have EMR at the community level also. When we do door-to-door screening, we have EMR. So when you say EMR, when they say refer, immediately the alert will go to a vision center. Vision center will know these are the people who are referred. So they will call these people to come and access care at the vision center. The same alert will go to secondary center also. And the second thing EMR is done is at the vision center level when we do EMR. So they have a tele-ophthalmology system where they say referral. It's an emergency, immediately it's put as red. The doctor sitting in the command center will immediately get alerted. This is an emergency referral, immediately has to be taken care. The alert goes to secondary center also. So people will call and make sure that this is an infection, this is an injury. It has to be immediately transported to the next level of care. What we have found that people who come, injury patients, if they come within 48 hours, the chances of recovery is much better than compared to when they come after 48 hours. So that paper we published again in Lancet Regional Southeast Asia. That is one thing. And then there are yellow referrals, and 90% of referrals are taken care. Suppose they were referring in the past, now say infections or say allergic conjunctivitis, the treatment is given by doctors through teleophthalmology itself. The third thing is EMR is done when I see when you, as a specialist you go to a tertiary secondary care center, you advise a surgery, immediately you can book a surgery. The patient doesn't have to travel again to tertiary center, again go through the same process of check-in, examination and all. Directly surgery is booked by the consultant at the secondary care, so patient can directly go for surgery. On the day of surgery he can reach and get the surgery done and go back. And the follow-up care again can be done at the secondary care level itself.
Okay, thank you so much. Asha, we have one question. Ash.
I've seen a lot of self-screening and follow-up that is done by the patient itself.
Yeah.
It doesn't come under any of these categories that you showed. So how much of follow-up actually actively happens is that as a percentage in your entire
follow-up if you are at the doorstep, follow-up in the secondary care is almost 85 to 90% for people come for follow-up for their cataract surgery or say keratoplasty, I could say. Just giving example of keratoplasty, we have almost 85 to 90% 1 year follow-up rate. The published paper we published in BGO, we found that people who were operated in tertiary center at the same time, the follow-up rate was only 25-30% compared to in secondary care it was 80 to 90%. Because we are at the doorstep, they know where they have to go, but at tertiary center they come from far off. They get lost. So what we say, most of them might be we also send them to our alumni group is there. We tell them you go and follow up there, but we don't know how many of them have gone to alumni. So right now we are going to track them, like what happens to each one of them. Self-testing, there are apps coming up. WHO Eyes have come with an app. We have written that paper on WHO Eyes, how sensitive and all that it is. It's a very good app. And now Infosys is coming with an app called Site Connect. I think we are working with that. It's very primitive to present the data at this point in time. WHO Eyes paper recently, just now we have sent to BGO. And once we have that data and once we have, that was just testing of the app. So right now that app has been tested. Now we are testing the Infosys app. And if that app works, probably we'll roll it out to the population also.
Thank you.
Yeah, Ashi.
There's this one question that has always been in my mind. I wanted to ask Dr. G. N. Rao. You are there, so you please tell us. That is
You can
about
call.
why we are not. Why do you think scientifically camps are not the way to go?
Because you are camps, you can do a camp and then operate and leave them, and then follow-up care is not. You may go for a 1 month follow-up, but what happens after 3 months? He develops a CME or he develops a detachment. Where does he go?
So
90% of them will not have anything, but what happened to the 10%? They need to go somewhere. Then if you are there, they know that this hospital is there where I was operated, they can go there, follow-up care. You have to close the loop, Ashi. Unless you close the loop, you have done the intervention, but loop is not closed. You have taken the responsibility for their lifelong eye care actually.
is it completely irrelevant now?
camp approach is like, I'm not say irrelevant, because there are like, everybody can't have a secondary care or a vision center, but these are the models which you can emulate over a period of time. In the future, I think that's the way to go. Instead of having camp approach, I think everybody is behind vision center now. There are so many vision center which has come up. When we built the first vision center, I won't tell the funding agency, but they said this will not work. Just throw it off. They didn't fund even also. We got from some other funding agency to vision center, and now I think if you look at the data now, the entire world is behind vision center. The donor come to you and tell that, please, are you developing vision center, building vision center, take the money from me. Yeah, Ashi will tell you. Don't the donor come to you and tell that how many you develop a vision centers now? Yeah, they come to you. Yeah, if you want, we can connect you with the donors and they can come and.
Yeah, thank you so much.
Yeah.
I think, Ashi, you asked for a, camp approach. I think there is a need for a modifying approach for a camps also. It can be a very good tool for, patient education, awareness, screening, if not surgery. Surgery may not be applicable, but other way around, we can use this camp approach, and it has been a very successful model in the past. Now we understand the information technology, the telemedicine has made things simpler, but to have people together in one area physically and somebody speaking to them will make a huge difference. I think we need to sit down and reform this, our camp approach in a different way. You have a very good point there. Thank you, Ashi. Now I invite Dr. Reena Sethi. She's going to talk about how to make the surgery effective in a community. That is, least expensive surgery and best quality. I think quality should be maintained. That should be our approach. Best quality with least expenses and better, facilities. Reena, all yours.
Thank you so much, and a very good morning to all. I'd just like to add one thing about the camps. We've noticed, we've done a little study also with our camps, and we've seen that when we have camps in the outreach, we have a lot of women coming in the camps. And when we have a clinic at our hospital, we have less women and more men coming. So I think that is one thing also has to be considered. Yes. Okay. So cataract surgery, the sight restoration and the cost-effective approach. Now that we've got the camps and we've got the patients in for cataract surgery, we need to restore their vision. And what is going to be our primary goal is that they have to have quality of life has to become better with the correction of vision. And we know the common techniques that we do for our cataract surgery are phacoemulsification and small incision cataract, manual small incision cataract surgery. And we have our successful parameters, which is the visual acuity and the improvement, and most important is the patient satisfaction. So these are the two different approaches that we can take or consider in our camp patients. They have their advantages, they have their disadvantages. One is a low cost, minimal equipment, effective outcomes, and low resource settings are required. The other one, that is a phacoemulsification, is quick recovery, better for complex cases, and much faster if you're once well versed with phacoemulsification. But the equipment cost and the other paraphernalia is much more expensive in phacoemulsification. Now the financial planning has to be done for these patients who we brought into our hospital. We need to be offering a tiered approach for their surgery. So basically, if we consider our example of our hospital, what we do is we do a cross-subsidy module where we have the non-paying section, the patients who are coming from the community outreach camps. Then we have the subsidized, and we have the patients who are paying. So the ones who are paying, they pay also for the patients who are bringing for the camp. So this is a cross-subsidy model. We have the NGO grants, as well as we have now a lot of good, things in which we can have the PM funds, like you have the AIOS2025, the PMJ, which do, and they've given the patient a bit of a dignity when they come into the camps. They have the card, they feel that they can demand the service. So that's a very good approach, I think, which are at the moment we are having. So we also need to explore a lot of other partnerships, as well as the other organizations who are doing NGO work and have funds to do something for the eye services and the CSR part also. which the 2% profits have to be given to a community-based organization. The cost optimization in a surgical procedure is what we need to understand. We have limited resources, we need to make the best of it, and we need to give the best quality to the patient. So we need to reduce the cost in our hospital. The only important thing here is we need to standardize it. It has to be like an orchestra. The patient comes, people must know who has to take care of the patient at what level, and they need to come to the OR, and the OR also, everybody should know their responsibility so that everything runs very smoothly. And implementing batch processing is very important. So you need to know that, okay, I'm ready for 20, I'm geared up for 20 patients, free patients, or 30 patients, and everything should be very systematic, and proper SOPs have to be followed there. You need to reduce the cost through high volume surgical, because the number of patients you do, it's going to be easier on your financials also. So increasing the number of surgeries per session optimizes your workflow. Training your staff, like I said, to perform efficient patient preparation, post-op care, minimizing the turnaround time between surgeries is the important part. We need to reduce per patient surgical cost as well. So implementing task sharing among the trained paramedical staff to reduce the burden on the surgeon. So this, if you have somebody who's going to load up your lens for you, I think that is one thing that really is a step that can save a lot of time. And if you have multiple tables, like you have in the other systems, in other hospitals which are doing number of surgeries, then the nurses know that they need to prepare the patient earlier before the doctor gets free. So that way you run a faster system, and you can adopt Indian IOLs, which are so good that they can also give very good results to your patients. Maintaining quality while reducing the costs. Well, you have a lot, this is a challenge, then we can now go and doing different challenges, but there is a solution, and that is the SOPs which you make, maintain the quality regardless of the cost cutting measures. Regular monitoring of your outcomes is very important. You must have a proper registration in which you know what complications you had and how you're going to overcome them, or wherever there was something that needed to take more time, so you need to solve the time issue as well. And use cost-effective yet reliable surgical techniques like the manual small incision technique that maintain good patient outcomes. Efficient use of surgical instruments. So you may have more reusable instruments rather than disposables like we have in the US and the other places. We have the autoclaving ETO system which has to be used. Prepare proper kits so that you don't have to keep looking for instrumentation. That is one thing very important when you're doing your surgery. And the protocols for proper maintenance and longevity of surgical tools. So invest in good surgical instruments which can be used again, but need to be, they have a good life. Organize them well so that you know where is what, and not, you need to have one black box also for you, for in case you had land up in a complication, you need those kind of instruments, they should be also ready at hand. Efficient sterilization and maintenance is very important. We don't want to have TAS, we don't want to have endophthalmitis. So we need to train our staff to have proper sterilization of the instruments. So training of the staff for proper sterilization techniques is very, very important. We need to minimize the post-surgical expenses as well. So most of the medication, which are generic post-operative medications, where we know that they've been, can be used, should be given to the patient. Educate the patient as to how they have to use their drops, or post-op prevention infection is very important, because sometimes these patients go back into the community and then they may not come back to you, or with the follow-up is not that rigid with them over 1 month, 2 months. So all the more the prevention tools should be given. What we do is we give them a QR code. Everybody has a mobile. We make them see the video. All the do's and don'ts are explained to them. So that is a good memory lesson for them also. So another financial constraint is the limited funding in our surgical programs. Apply for government subsidies, grants dedicated to eye care. CSR is available, so knock at the doors of these big firms and ask them for some partnership. And implementation of the tiered approach is also a very good model to take care of these patients. The challenge also is in the program initiated with external funding. We struggle to continue independently, like Dr. Arun said, that you may get it for a short period of time, but then after some time your finances, they just die out. Then what are we going to do with the patients? So here again, you have to do some income generating services within the eye care programs. So what you can do is the paid patients, they pay for the non-paying patients. So cost subsidization model is very important. Low patient awareness and engagement is a challenge. So you need to conduct community outreach programs to educate. So your camps should not only be for collecting cataract patients, they should be for prevention, for education, and to tell them about all these taboos which they have in their mind, the cultural beliefs, not getting operated in summers, etc., and so many other things which need to be made, they need to understand. So you need to have good counselors in the camps to make them understand all this. There's a challenge of shortage of trained ophthalmologists and surgical assistants in rural areas. So there's a lot of mismatch. So high training costs are there for these skill enhancement programs. So the solution is to train local health workers, lift them off, you have the ASHA workers to identify cataracts or other problems in the community, implement task shifting strategies where trained nurses, paramedics can handle pre-op and your post-op so that they can identify if there is a problem and then refer them back to the hospital. There could be some infrastructure limitations also. So you need to optimize your existing space to create multifunctional surgical units. So invest in basic but durable equipment that can withstand frequent use. There are a lot of logistic barriers also to the access. So organize mobile eye camps to bring services closer to the rural population, collaborate with local authorities to provide transportation support for the patient, and set up the telemedicine consultation, which is a very good tool to identify so many problems which are there in the rural population, but yet they cannot reach the hospital. And one last note about the post-operative care and the challenges. So inconsistent follow-up care could be a problem in most of the patients who are coming from very far off. So develop a follow-up protocol that is easy to implement and track. Train the community health workers to follow up and conduct the home-based follow-ups for them. And always we need to monitor and evaluate all our data because we need to grow. And to grow, we need to know our data and to know whether we need to make some more amendments in our different policies. Thank you very much for your patience listening. Thank you.
Thank you so much, Dr. Reena. I think we'll take question subsequently. Invite Dr. Hina to take us through the approach Arunodaya saga, reaching the Unreached.
Good morning, everyone. I'd like to thank AIOS and Team Arunodaya for giving me this opportunity. My name is Dr. Hina Dharamdasani, and I'm doing a fellowship at Arunodaya Deseret Eye Hospital. So Arunodaya Charitable Trust was founded in November 1990 with a chance encounter with Dr. E.W. Jackson of Deseret Foundation, USA, leading an inception of ACT. It's a registered non-profit public welfare trust that works in the field of curable blindness in Delhi NCR region. It has reached more than 17,51,062 needy patients since 1990. It has 3 different clinics in Delhi NCR region. Over 57,814 sight restoring surgeries have been successfully done at the base hospital. So the objectives of the eye care project are to reverse the tide of curable blindness, especially in economically weaker sections of the society, to increase eye care awareness, increase the knowledge and skill transfer among the friends of ACT, and to provide comprehensive eye care to the community. Here are a few glimpses from our outreach programs. So the ACT Care project has 4 components. It has a mobile ophthalmic unit, the school screening programs, the base hospital, and the satellite clinics and camps. So our mobile ophthalmic unit covers the industrial screening, rural screening, the NGO network, health education and awareness. Our school screening program are including the teacher training, the student screening, prescription of glasses and active intervention in patients which is required. The base hospital provides comprehensive eye care, screening programs, specialty clinics, surgeries for patients who require it at the camps, and refraction and glasses is being provided. The satellite clinics and camps is screening being done at the camps, referrals to patients who require surgery, identification of patients who require them, eye care awareness, and refraction and glasses are being done at the satellite camps as well. So the mobile ophthalmic unit that we have is equipped with a speaker system to propagate the eye awareness at the village level. We have a portable slit lamp with us there, an auto-refractometer, non-contact tonometer, portable fundus camera. We have 2 such vehicles now. Here are glimpses of the mobile ophthalmic unit that we have. The school screening program, we have screened over 30 schools with more than 50,000 patients have been successfully screened in the past 3 years. It was found that more than 11% of children were suffering from undiagnosed refractive errors, amongst which myopia was the most common one. And the prevalence of amblyopia among these patients were 0.8%. At the base hospital, the Arunodaya Deseret Eye Hospital, it was inaugurated in 2005 on 1st October. It follows a cross-subsidy model where nearly 70% of poor patients are treated free of cost or at a nominal price, and the balance 30% helps in the institution of revenue for the operational expenditure. The satellite clinics are at 2 other places in Delhi NCR region. The aim is to identify and screen patients who can't access the base hospital readily. Cases requiring further investigations or surgeries are referred to the base hospital. Next are camps. So here we make sure to screen all the patients which require treatment. So pre-camp campaigning and training of volunteers is done and teachers. So camp setup and screening is being done. Distribution of free and or subsidized medicine and glasses being provided, and referral of patients who require further investigations to the base hospital. Here's a glimpse of our camp where initially we register and check vision for all the patients. The refraction is being done at the campsite. There's a doctor consultation which follows, and then there's distribution of medicine and spectacles as well to the patients at the campsite. There's patient counseling for the ones who require surgery or further investigation and management. And the patients who require surgery are being transported to the hospital, and we're operating at the base hospital. So these are the ambassadors of site, the Deseret International Foundation USA, Charity Vision USA, Head Skyld Netherlands, and many more. Here are a few glimpses from our outreach programs. So totally we have, the total number of patients who have been treated are 17,51,662 patients. The total number of patients that have been operated on are 57,814. The total number of spectacles dispensed by us in an outreach program are 99,165, and patients which are given free of cost medicines were 90,842. Thank you.
I think wonderful job from the team, you know. Any questions at this stage before we shift to the next talk? Yeah, sure.
For 3 years around 30 schools and 30,000 kids were screened, right? So they were with refractive errors. What happens in their 2 years before, 1 year before? Do they get corrected glasses? Or did they go through, was the loop closed? That was the same question that Dr. Ashi asked to Dr. Rohit, right? Once you go for camps, what happens?
See, there are 2 approaches to this. One is how close the school is to the hospital. Can the children come on their own? Second is to go back on a routine check every 2 years or 6 months and see what is the adaptability. Are the children using the glasses? Have they broken them and they need any replacements? So that goes through the government channel. The unfortunate part where we're working in Haryana is that we were given sponsorship only for one time to do it. We went back once again to check. After that came COVID, and a lot of things stopped. And now you see they have not been able to revive it. So there is a point there that when you give glasses, you need to go back for follow-ups and to see them out of them. What's anybody? Dr. Saiba would probably be able to tell you. She does school screenings and whether we have other issues like finding out, ocular disease and how you handle.
Yeah, thank you so much. I think can we have the thing later? Yeah, invite Professor Parveen Basist for the next talk, and he's one person who's transformed the community ophthalmic services at AIMS New Delhi. He's professor in charge of that services, and he's one of the main person in AIMS administration also. He's a link between AIMS and government for various health-related program, regulation, all, and he is also Vision 2020 Vice President. He is a licensing of WHO program for AIMS also. Thank you, Praveen, and I think he'll highlight all the things we have achieved in AIMS New Delhi.
Thank you so much, sir. In fact, the most important thing is I worked with sir, and sir is a constant support for us for our primary eye care program also. I sincerely thank Sethi sir for inviting me for this session, including in last minute, I believe. I'll be talking about some of the activities that RP Center is doing in community in order to strengthen the primary eye care. In fact, this is the current scenario in our country. We initiated Vision 2020 Right to Sight in 2004, and at that time we planned that by the year 2020 we'll have 20,000 vision center in the country. That was the need, one vision center for every 50,000 population. But when we evaluated in 2020, we got nearly 4,000 vision center only. That means there is acute shortage of vision centers as far as primary eye care is concerned in India. But why do these people, everyone start vision center? I have never seen, very difficult to see vision center by government hospital. RP Center has tried it for long, but most of the NGO hospital, they run standalone vision center, whether it is LV Prasad, Arvind Eye Care System, everyone, it is mainly the standalone vision centers of their eye department, and there may be different reasons to publicity of the hospital, to increase their OPD in the hospital, and sometimes, yes, major initiative to reduce the burden of blindness in the entire area. But in government hospital like RP Center, I know that we are already having a huge burden of patient in hospital. Nearly 6 lakh patients are seen in 1 year in eye department of AIMS. And when we try to promote eye care services in community, then we, in fact, I still remember my previous chief, he said, why do you want to bring more patient to us when we already have so much of burden? We are giving some dates to patient even after say 6 months or 9 months for pediatric surgery or something. That is the actual situation in our hospital, maybe in other government hospitals. But still, we actually initiated this primary eye care services. We said at least nearly 30-40% patients who are coming with refractive error in RP Center, those patients can be seen in community, and effectively number of patients will reduce, and only referral patient will come to the tertiary care hospital. So our aim is basically to eliminate avoidable blindness in the community, and in fact actually reduce the burden of such patients who can be taken care at the community level. And the key services, what we believe in comprehensive care. It is just not for refractive error. We are also doing DR screening, we are doing glaucoma screening also, training of the volunteers, specifically the ASHA volunteers in our programs, and of course post-operative follow-up is also done. Our model can be divided into 4 different categories. One is we are using the integrated approach where we are working with Delhi government in their dispensaries. The second is recently, last year, we started Project Roshni with the support of CBM, where we are developing vision centers and low vision facilities in other AIMS and RIU. This is part of the government system. We are trying that other AIMS and RIU, they should also have primary eye care facilities. Of course, we have another model. We have involved local NGOs. They are sponsoring this program, and they are inviting us for primary eye care services. So it's an NGO-based models. And of course, most important for any primary eye care is community involvement, where ASHAs, CHOs, and school teachers are being trained and involved. So it is basically, one is the integration with Delhi government dispensaries. Again, we believe in total cost-effective approach. Infrastructure is provided by Delhi government. Medical officer is already available. Some of the manpowers like ASHA worker, ANMs, nurses, they're already there in those centers. What we are providing is additionally optometrist, data entry operator, and one more worker, team of 3 people, and no money is charged from any patient. It's totally free of cost. Even spectacles in Delhi government dispensary, they don't allow us to even charge 200 rupees as subsidized rate for spectacles. So what we are trying, with the support of various agencies, we are arranging free spectacles in Delhi government dispensary. Especially the press biopic spectacles is given totally free of cost to the patients. So no cost to the patient at all. Medicine is free through Delhi government. Spectacles are free, and no money is being charged in Delhi government dispensaries. In NGO-based models, where NGO they invite us for screening, it's a regular screening. Some of the local NGO like Dipalya, SSMI, Divya Jyoti Jagriti Sanstans, they are even funding our project teams. So no expenditure on AIMS. I'm sorry. As far as manpower is concerned, patients are being mobilized by these NGO workers. This is another important thing. Again, free infrastructure is provided by NGO. They have volunteers. Subsidized spectacles for 200 rupees is being arranged by our teams. Medicines are given by RP Center, and all such patients are being referred for free cataract surgery in RP Center. We have a community eye care programs. 30 beds are under community ophthalmology. We provide phacoemulsification surgery with foldable lenses, totally free of cost to the patients. So nearly 3,000 such patients are being operated per year under community eye care program in RP Center. So this is something which probably no other NGO is doing such kind of programs. And our average OPD, minimum is 40, maximum is 120. Average is 67 for the last year, 67 patients. When I compare with other NGO hospital, the average is around 15 to 20. But we get 67 is the average last year. So you can understand the utilization of services is probably very good, and it makes the system much more cost effective. We have one vision center with all the best facilities available. You know, even the ophthalmologist is going thrice a week in this center, and all portable equipment you can think of, they are available in this vision center, whether it is for DR, whether it is glaucoma, and other routine screenings. This Project Roshni, which I mentioned, we started last year with the support of CBM, where we have like 5 vision centers in Delhi and 8 vision centers in other satellite centers, beside providing low vision services. And I'm happy to share that under this Project Roshni alone, we have seen more than 1 lakh patients last year, more than 1 lakh patients in 13 vision centers, and our target was 83,000. So you can understand, even such kind of program which was initiated even last year, we were able to achieve targets in 4 RIOs and AIMS, including AIMS New Delhi. Our total number of OPD in 1 year, 1,75,000. I feel very proud of this number, but when I compare with Arvind and LV Prasad, then I feel depressed. These are 27 vision centers, as I mentioned, screening for diabetic retinopathy, glaucoma, school vision screening program in the catchment areas, even going to school for blind. Everything is embedded in this one common program. In fact, we also have a reach-in program for cataract surgery. It's basically screening camp for cataract. So again, we have partnership with local NGOs. They conduct camp. They provide services for referring patient, bringing patient to RP center, and we provide free services. This is plus everything for the patient actually. And probably the best part I feel is we are using this free open data kit platform for data management. So it is basically data is available, is being entered in mobile phone by the team members. It is going to AIMS server, and then from the server itself it is analyzed, and it is being shared to the team members on same day by the evening actually. And it is available totally free of cost. So online data kit is there for data entry and data management, feedback to the people, and free of cost. Not even a single paisa is being used. If any other agency want to use this thing, we'll be happy to help for online data kit platform. See, within one stroke of computer, we can have this figure, what is the percentage of various disease being seen in our primary eye care centers. Nearly 50% are refractive error include presbyopia, 15% is cataract. Another important initiative is basically we are doing this awareness about eye disease using the various posters. In fact, these posters were developed by our team. Now Government of India has adopted this poster and disseminating all over the country. This is one advantage where I feel working at AIMS, that we're directly in contact with Ministry of Health and they're using our work for welfare of the country. I think this is my last slide. I would like to mention about special program for primary eye care worker, ASHA worker. I think somebody, Mr. Sethi mentioned that in Gurgaon you tried and there is no funding for that. And we ensured that there should be some funding for ASHA worker. We met the Health Secretary of Delhi and happy to share that they initiated. For cataract surgery they are giving 400 rupees. Even if one spectacle is provided with the support of ASHA worker in their area, they get 100 rupees. ASHA worker in Delhi, and it is included in the program in Delhi. In fact, only after starting this thing, we initiated one PhD study, that is how to strengthen primary eye care using ASHA worker. That study was completed and recommendations have been given to central government. Before that, ASHA worker were rarely used in the eye care program. I'm happy to share, because of our work, now ASHA worker are being involved in eye care program. We had a ministry, there's a committee in central government, in NPCB. In that meeting, it was decided that country level incentive will be given to ASHA worker, especially for screening for cataract cases. I am sure this will be implemented very soon, within few months of time. Thank you very much. Thank you so much.
Thank you, Parveen. Wonderful job, wonderful work you are doing, and appreciate all the efforts. The day you can succeed into getting all the 22 aims together, the community work, so you will be not depressed. You will be better than any other institution at that time, because you will be covering every width and breadth of country. If you can get all the aims together. Thank you, and I think it is it's not only the NGOs who are doing great work. If government supports that idea, if NPCB becomes active now, which was earlier, and the Health Ministry of State and Health Ministry of Central Government, they form a good regulations, support these systems, I think we should succeed into getting a better outcome in every area. And I think all of us have something to do there also. Let's invite the next person, and one of the most prominent person in our country, across the world he is known, and person who eats only chilies every day. So he can take us through the various diabetic retinopathy programs, and Dr. Natarajan, you all know, is a wonderful clinician, and actually he is a researcher, and worldwide he is philanthropic. Dr. Natarajan, please.
Thank you, Dr. Thank you, TTL, and thanks to Arun for inviting me. My good friend Jerry is here, whom I first saw as a resident in '83 in the Bombay conference, where I met Fidrao and many others. Anyway, I thought I'll do IOL that time. I never knew I'll go into retina the next year. So the topic I took is taking eye care to doorstep of Mumbai slums. I decided, seeing the busy Mumbai, we had a clinic next to the Fan railway station, and then I used to see that the people keep running between the station and their home, and nobody wanted to come to the clinic. The reason was they're all working for their bread butter, and that's why they run. They don't care about their health. So I decided we have to visit every house, and so Mumbai slum face significant healthcare challenges, including access to eye care. We have the Sion Medical College, the Lokman Ethelic Medical College, which is in the heart of the slums of Dharavi, and where the slumdog millionaire was taken. And now I am an emeritus professor of ophthalmology there only to serve. And I think the reason is the patients don't have time to walk in. It's just 500 meters. Another 5 meters other side we have a vision clinic in the slum for the last 25 years. Because my father said, he was an ophthalmologist, he said, you are a busy practitioner, you have to do something for the poor people. What are you going to do? So I started doing charity from '88, but 2005 we made this foundation, and I decided to do free eye care. Large portions of population live in overcrowded areas with limited healthcare resources. Eye-related issues like cataracts, refractive errors, and infection are common but often untreated. So the geographical barriers, slums are often located in areas with limited access to healthcare. Actually, there are municipal clinics where inside the slums, but people don't go, and that's the problem because they're all running around to make money, and they have a lot of money, but they lose their health. And I think, according to me, they just die without. Because they're all from all over India, and they come to Mumbai hoping for a big breakthrough, but unfortunately the area is so small. It's 7 islands merged into a peninsula, and people, the rate of land is very high. And high cost of treatment and surgeries make access difficult for low-income residents. And lack of awareness, and that's the biggest problem, I think, all the rural and slums. Many people in slums are unaware of the importance of eye health or available treatment. And healthcare services in Mumbai are often overwhelmed, especially in the slum areas. So the problem faced in our health system, sometimes the unreliable internet coverage, which is not true for Mumbai, but it's for the villages nearby, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus camera and portability of conventional fundus camera. So we have done this. We have social workers. Earlier, before COVID, we had 30. Now I am again building up. So we go door to door, and I think we have a better statistics than the Mumbai Municipal Corporation. And I work with them. We have an MOU, but still, we unfortunately are using the books and papers to write their data. I think the social workers have the data of their family, their income, their what they need, not only eye care, they also talk to them for their gynecology or urology, whatever they want, even though the hospital is nearby, but they guide and they have access to every house in slum. And when I go with them, many times they are lost because it's like a maze, you can't come out on your own. And we also do, there are a lot of schools within the slums, and we do school screening camp. And my father insisted that I should go and give talk on how to take care of diabetes and diabetic retinopathy. I used to tell them, what do I do with the school children? He says, no, they have grandparents, and if you impress them, they may go and with love tell the grandparent, come for the eye checkup, or they may bring. So this is what we do every day. I keep telling my residents and the doctors who work with me that we should conduct, apart from the screening, we also teach them the parts of the eye and also how to take care of the eyes. So this is a general eye screening camp, and wherever we have space, sometimes in the small temples inside the slum and sometimes in the community hall, we keep doing. And we also use the low-cost screening devices at primary eye care centers. So we go in almost inside the slum everywhere and create this center. And this one on the top right is a Zeiss camera, thanks to the World Diabetic Federation, where they gave a foundation from Denmark. They gave us the grant in 2012 for 5 years. And then we had a van, we had Zeiss camera, it's still working, and we have Zeiss laser. And the idea was them to give the know-how and also do a capacity building. And these are some vision centers in various slums of, because we have 2 million people living in Dharavi, another 4.5 million people living in the whole Mumbai slums. It has I recently learned the entire Mumbai is made of 23 islands, which is up to Malad and Dahisar and other places. So we do all the slums. You can see sometimes we get a place under the tree, we do the screening, and we are not shy, and sometimes the smell is so bad. So I hope one day to teach them the Swachha Bharat, apart from eye screening, to teach them cleanliness and hygiene. I hope to do that. It's a tough thing. I mean, unfortunately, now the Adani has got into that Slum Rehabilitation Act. They are claiming they are going to make it like the BKC or the Dubai, the entire slum rehabilitation. I hope it will happen. Because 1992, the former Prime Minister made the Slum Rehabilitation Act, and Slumdog Millionaire came. Several movies have come. Still, there are 25 tourist companies taking all the foreigners to see how these slums they are living, and sometimes they also have somebody lives there, because there many things like leather products may be made here in Dharavi and goes to Europe with a Gucci and other things, and nobody knows that. And thanks to my friend, late Dr. Abdul Kalam, every day, he always was my motivator, because he used to tell me, you are a big gun in retina, what are you going to do for glaucoma? And he was aware of so many things in ophthalmology, very impressive. And whenever I called him, he was a president, as a past president, and even before president he came, and this is one of the functions in 2010, he used to come and visit. The idea was to make him meet all the social workers and encourage them to work. And thanks to here, my late grandmother was inaugurating this motorbike, where thanks to Forest, Mr. K. Chandrasekhar is there, no financial interest. The fundus camera we carry in the motorbike and inside the slums. So it was old called Aditya Jyot Foundation for Twinkling Little Lives. Dr. Kalam gave me the name of this foundation because his friend was Dr. Reddy, who has the Little Heart Foundation, and he told me, why can't you do some twinkle in the eye? Dr. Natarajan used to tell. So we have this van, and if you take a regular fundus camera in a motorbike like this, the optics will go. So we have this boy who's a 9th standard pass. He carries the optics in the backpack, and then the hardware in the box, and then he can reassemble in a few minutes. And then this is what we do. We go to a community area, check their vision, and then in case with the dark room and the 4mm we can take photograph. We do that, and I think 45% we can do without dilatation, and 55% we use 1% tropicamide, which has been now used by the various studies in UK, and found the angle closure glaucoma is almost nil, even though we are aware of it. So we are aware that if there's a problem, they'll be referring. And you can see they can take beautiful pictures, and this can be connected to AI. And the other company which I work with is Remedio, again no financial interest. The computer is trained to accept retina pictures properly taken by the trained non-skilled worker and make him into a semi-skilled worker. That means give him one skill. I have spoken to the National Skill Development Corporation in Delhi to give them a 3 weeks training, and we made a curriculum, but unfortunately after the COVID we could not follow up. Now again I think I'll have create time to do that, so that we can give a certificate to the people who are not past 10th, because the skill development is given to a person after passing 10th or 12th grade. But we want to encourage people without any school dropouts to get this training. So we have 647,645 villages. Only our Prime Minister has access at one go every year to talk to the villages, village panchayat, which we don't have. But we can't do that screening, but I want to screen. I know it's a mega project. Maybe it cannot be done in my lifetime, but I think I want to initiate it. And so this is a picture which we can, the picture can notify the staff. That means he doesn't know to read English. So that's why instead of the Romeo police in UP, I want to tell the UP Chief Minister, we can train them to do the retina photograph, and then that AI will tell this patient needs to be referred to the diabetic retinopathy, and this need not be. So this is the one which can be more. I can take a minute, Dr. Chetia? Okay. So can be mounted on a suitable bike, you can transport, can be mounted on any table, and both the mobile phone, it's an iPhone 5, 6, 7, 8, again I don't have any. I tried contacting the iPhone, that Tim Cook, I tried meeting him and to ask him to support where all the villages, and the other one is Google, but anyway, Google has their own program. But I'm happy we are working with this program from 2017, and it's chargeable. You can see.
In order to acquire an image, please ensure infrared view of the
So actually you can see that anybody can be trained.
you are able to touch the screen to autofocus. You are now ready to take a shot.
So you can see they can take a good photograph, and then now the Remedio has come out with the 3 software for ARMD, diabetic retinopathy and glaucoma, and we can capture the fundus curve like this. We have trained, and then we have several projects in the slums called CREAM project for the children refractive error, and earlier we called it AJ drums, and we also had Dharavi war against diabetic retinopathy. But the whole idea is to reach all the 6.5 million living in Mumbai slums, and I want to take the eye care to them totally free. And fortunately, Mumbai people are very nice and kind, and they have given a lot of money. We have now recently got a 15 crore worth property for doing a charitable work, and another 3 foundations are giving me 5 crore. It's not enough. I have asked for more because we want to employ and pay the doctor well so that he can do well, and then he need not look for private practice and do surgery. And we can make India free of the burden of diabetic blindness, and teleophthalmology can show us, and eye care can reach every village via teleophthalmology and artificial intelligence. Thank you.
Thank you, Dr. Natarajan. I think, a wonderful initiation, a lot of good work, and best wishes for your cream and drums.
I hope all of you can come and have a look.
Sure,
one
sure.
day.
Yeah, let's have Baba set up the talk because we have a very little time.
Yes, thank you. I think thank you for this inviting me for this session, and I think this is a pertinent talk after Dr. Natarajan's talk on how to screen diabetic retinopathy, especially in the Indian scenario. So the main problem that was highlighted is that the type 2 diabetes is evolving and is really increasing in especially India being the heart of diabetes in the world. And you can see by 2030 we're going to have 101 million population who are type 2 diabetic, and it will go up every year. The national prevalence itself is 8.9% across the age group of 20 to 79 years. So 1 in every 11 adults is affected with type 2 diabetes in India, which is very alarming. And high proportion of these patients are underdiagnosed. They are not diagnosed at all. And among the diagnosed also, up to 50% of these patients have poorly controlled disease. The main worrisome problem and the problem that we need to solve from the eye perspective is asymptomatic DR, because 90-95% of population who have diabetes, who have diabetic retinopathy, will not be aware of it because they will have no symptoms till it's sight threatening. So AIOS, VRSI, Queen Elizabeth Diamond Jubilee Trust and WHO have come out with various DR screening guidelines. But the key points on the guidelines would be there's a need for population level screening for diabetes and its complications, and an integrated approach is required for people with diabetes to minimize blindness due to the retinopathy. So there are factors in previous experiences which are for promoting success. Equitable and widespread access to laser treatment and trained staff is very important, because we want to basically have an end-to-end loop so that we not just diagnose it, but we treat it there itself. That's very important. Otherwise, this patient again will have to come for a re-evaluation and we lost to follow-up. Initiation as local screening programs that can scale up, and screening offered at locations and times that meet the needs of the patient. So maybe doing a day screening camp may sometimes be less effective than doing an evening camp, which may be more effective in that particular subset of population where the people are working. So it's very important that there should be a buy-in from the healthcare professionals, the patients and their families. It's very, very important. It has to work as a team. And as has been shown previously by Dr. Rohit and Professor Praveen Vashisht, that accurate data collection, review and reporting is very, very important for you to understand if you're going right or you're going wrong. There are challenges and barriers to screening, which is very important to understand, that because of the decentralized healthcare or many private insurance-based healthcare, they have low success. And eligible population of screening increases every year as the population increases. And majority of patients do not show up because they have no symptoms. And even though you tell them that you're diabetic, you need to come for an annual follow-up, still they don't come back because they have no problems. Less than 85% uptake in the annual eye examination invitations observed consistently in England and other parts of the world. So this basically tells you that though the patient is aware he has the problem, he may not come to you because he has those symptoms. So very important to have a way forward in diabetic retinopathy screening. Systematic tele-screening programs, as has been highlighted by the LVPI and the AIMS program, are cost-effective, which can be done by a trained technician, not just an ophthalmologist, because you need to have people who are locals so that they can be volunteers and they can be part of your team who can take care of this at your base level, the rural area, the vision center and the primary eye care level, because you need to have a very good and strong tele-ophthalmology bone so that you're able to have very good screening, and this can be seen by the ophthalmologist at the tertiary or secondary level, and patient who requires treatment has to be referred as per the triage, and then they can be treated. So that, and a feedback loop is very important so that you know the patient has gone there and has got treatment done. So using non-physician graders for initial screening at these areas is a very important part of the success in the way forward. And establishing your screening pathway is very critical. You should know the flow in which from the base level to the tertiary level, how the patient will be screened, followed up and monitored. So not just treating them once, because diabetic retinopathy requires multiple laser therapy, sometimes it requires injections, it requires follow-up, so you have to have a proper monitoring course and follow-up course. So internal quality assurance and external quality control mechanisms are very important. The AIOS task force recommends at least 80% sensitivity, 95% specificity and less than 5% technical failure rates in such systems. So a whole team has to be certified and have to be involved. The involvement of ASHA, it has been nicely promoted now through AIMS with Professor Vashisht being there, that you getting ASHA, they're getting an incentive, because incentive is such a important, crucial aspect for them and for any worker, because they have to be rewarded for the work that they do. So it's very, very important that this should also be incorporated in diabetic screening. So every type 2 diabetic should be screened once a year, and that effort has to be made at the grassroots level with the help of the ASHA. That is the way you can actually track each and every person, because ASHA is the local person in the neighborhood who will inform the patient that he has to go for the follow-up. So key steps in DR screening would be identifying the eligible population, list everyone who has diagnosis of diabetes with the help of the endocrinologist in your neighborhood, as well as in the rural area. You need to make a holistic approach so that you can treat the patient as one. So guidelines, protocols, SOPs have already been discussed, but very important to have them to avoid any system failure. Follow-up surveillance is very, very crucial, and re-screening for screen negative patients should always be done. So important to have an important uptake. So not just screening, you have to also tell them how to prevent diabetes, which is the most important part, because prevention is better than cure. So knowledge, attitude and awareness and motivation of people at the grassroots level, how to avoid getting into the trap of not working and having type 2 diabetes is very, very important, because that will improve their overall the chances of us having less amount of DR in the coming years. Health education material, which has been very nicely shown with the help of the government flyers that we are available and templates that everybody uses, and very important to develop them in their own language so that every part of the India can disseminate this information widely and properly. The patient should be informed that he will require this much time in the screening program in the vision center. He would require dilation and what can happen post dilation, so that patient understands that nothing wrong has happened to him post the dilation, so that it should not be an unpleasant experience which he should not land up not doing again. So very important to allocate the roles and responsibility of each person, each member of the team, so that everything is done properly and they do their work efficiently and properly. Public-private partnership, which has been spoken about before, is very, very crucial in such situations, because the government cannot be everywhere. So it requires private partners, it requires NGOs who are doing good work in that area, and collaborate with them so that the efficiency improves overall. And we have now good schemes available since the past few years. The PMJ AIOS2025, which has provision which gives you a nominal amount of 8,000 rupees if you are NABH accredited for 3 sessions of laser. And unfortunately right now anti-VEGF injections are not included in PMJ program, but I think is very, very important, which should be the next step, that they should include that, because a lot of patients who require the treatment land up not doing it because of this main problem. Thank you very much.
Thank you, Dr. Weber, for a lovely presentation on diabetic retinopathic screening. Our last talk is going to be on glaucoma awareness and control, the way forward, by Dr. Sahiba Sethi.
Good morning, everyone, and I welcome you all to this very vital scientific session. And since we are on the subject of public health issues, I think glaucoma is a very pressing yet overlooked public health issue in our country, especially for two primary reasons. One being that it's symptomless. Secondly, it's not so evident to a doctor on a cursory examination, and a detailed examination is necessary. Now, the fact that it lacks symptoms makes it extremely hard for us to convince the patient that there is a developing disease and they may need timely intervention for for prevention of blindness. So, with that disclosure, moving on, why are we talking about glaucoma in the first place? We are because close to 12 million Indians are living with glaucoma, out of who close to 80% are undiagnosed or untreated. 2 million people are expected to go blind because of glaucoma by 2040. And we at AIOS, we feel that we should intervene before they give up. We are a non-for-profit organization. A lot has been spoken about that, and glaucoma has been our main focus amongst others. The model basically lies in the fact that we have community-based glaucoma awareness strategies through outreach camps, through which we screen the community for glaucoma. We identify the high-risk glaucoma suspects, refer them to the base hospital for a detailed glaucoma evaluation, and then they undergo relevant medication or surgeries with the help of donors. So recently we conducted about 3,980 camps, out of whom close to 1 lakh patients were screened, close to 23 patients were referred to the base hospital, and 192 glaucoma surgeries were undertaken. The methodology remains pretty much the same, a detailed examination with visual acuity check, slit lamp examination. Let's also remember it cannot be a torchlight examination for picking out glaucoma even if in the community. So portable slit lamps come very handy. Measurement of intraocular pressure through non-contact tonometers, which are portable, is also very important if you want to pick it up in the community level. And all the high risk or suspect patients are referred to the hospital for further evaluation. To aid us in this, we also have a state-of-the-art mobile eye van, which is one of its kind, and I think it's unique, and more institutes are adopting this. But we feel that it really empowers us and helps us give quality eye care even out in the villages. And this is equipped with vision charts, portable slit lamp, NCTs, non-mediatric fundus cameras, and makes the entire examination very detailed and thorough. Now, camps are not attractive to urban population, which is also the area where the problem of glaucoma lies and is undetected and underdiagnosed. So we've attempted to engage that audience through talks, skits, movie screenings, radio shows, and all these activities get heightened every year through our World Glaucoma Week. And I think the uniqueness of our model lies in the fact that we really believe in connecting with our patients, talking to our patients, and they in turn, a treated patient, a happy patient becomes our ambassador. And if we can treat one and one can pass on the message for a general checkup or generally taking care of your eye health to 10 others, and from those 10 others, maybe 100 more. So this is how I think we can target reaching the interior of the community for their betterment. And this is our hard-working, dedicated team, and I'm hopeful that we continue doing this service to the community and are able to make that drop in the ocean difference in the community as far as glaucoma is concerned. Thank you.
So in conclusion, we'd like to thank you all for coming over to spend your Sunday morning, 8 o'clock on Community Eye Health. It's a tremendous thing. It shows the motivation. The hall is well attended. We now request all of you to please come forward for a group photograph. And after that, you're welcome to meet the experts and clarify any doubts. Everybody, please come forward. Dr. Aditya, Dr. Weber, Mr. Sandeep Sharan, please come. Dr. Natarajan, Madam, please come. Dr. Saiba, please come. So we have had some of the top institutes from LV Prasad, All India Institute partners. Please come forward, everybody. Please come. Yeah. We're waiting for you, please. Yeah. All of you, yes, ma'am, please come. Nobody should sit on the chairs. Please come. Come along. We have a group photograph. Please come for 2 minutes. Yeah. Come forward. Dr. Reena, Dr. Prachi, please come. Gentleman over there. Madam, please come. Aaiye, photograph ke liye. Come. Yeah, please come. You're visiting from which place? Australia. Oh, that's nice. So they come from Australia to listen to our session. I could see you were being very hardworking. Yeah. So which part of Australia?
Rural, near Fargas from Sydney.
Okay. That's the teacher from US. Thank you. Everybody, please come. They're sitting there. Mark them absent, please. They're not coming. Aaiye, please. Come. Come this side. See that nobody is left out here. Ab aage aa jaye, sitting. 2 rows of sitting. Those who come late, please sit in the front. Come. Anybody left? Okay.
ऐसे बैठना बड़ा मुश्किल हो जाएगा, उम्र ज़्यादा है हम लोगों की।
So what's wrong?